Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Erica Morrison. Ms. Morrison, the floor is yours.
Thank you, Wes. Good afternoon and welcome to the webinar, Protecting Patients, Understanding the Options for Pneumococcal Vaccinations. As mentioned, my name is Erica Morrison, and I will be your webinar facilitator this afternoon. Today's webinar is brought to you by VHQC, a private nonprofit health quality consulting company that serves as the Quality Innovation Network, quality improvement organization for Maryland and Virginia. VHQC consultants provide outreach, education, and EHR services to providers and healthcare organizations across the region. Before we dive into today's webinar, I just want to point out two upcoming VHQC webinars that may be of interest to you and your staff. This Friday at noon, Hillary Wall, who is the Million Heart Science Lead from the CDC, will present on using your data to identify patients at risk for undiagnosed hypertension. To register, please click on the link in chat. This registration information was also sent to your email address within the last couple of weeks. We hope you will join us for that. Additionally, next week on Thursday, January 28th at noon, Robert Connors and Patrick Hamilton from CMS will speak on submitting your 2015 PQRS data, and will also provide an overview of 2016 PQRS requirements and the future of value-based incentive programs. We certainly hope you will join us for both of these exciting opportunities. And so thank you for registering soon. Again, those links are in the chat. So today's webinar presentations go hand in hand with VHQC's goal to bring measurable improvement to adult immunizations in Maryland. To give you a broad picture of the problem, this slide shows national immunization rates that are falling below the Healthy People 2020 goals. For influenza, the current national rate is just over 40%, with a goal of 70% by 2019. And for pneumococcal, the rate is almost 60%, with a goal of 90% by 2019. And for the last measure there, the current national rate is 20%, with a goal of 30% by 2019. So special emphasis is needed on reducing disparities among racial and ethnic minorities, as well as rural Medicare beneficiaries and dual-eligible Medicare and Medicaid beneficiaries. VHQC understands that many barriers exist that impact practitioners' ability to immunize adults adequately. Along with our partners and our contacts, VHQC is a resource for Maryland immunizers to assist in overcoming these obstacles that impact assessment, tracking, and documentation of adult immunization. So let's dive right into today's presentation by Dr. Lana and Tom Bateman. There will be opportunities to ask questions after each presentation, and you are always welcome to chat a question or comment. So now it is my pleasure to introduce our first speaker. Dr. Majmar, who we'll call Mona, is a pharmacy manager and immunization trainer at Walgreens. She is responsible for training over 100 stores in the Atlanta market. We're so glad she's chosen to spend time with us today. Mona, thank you so much. I'm going ahead and hand the call over to you for your team introductions and your presentation.
Yes, thank you so much for that introduction. My name is Lana, and we're going to cover there are two pneumococcal vaccines. Along with me, I'd like to thank my co-authors today for helping me put together this presentation. The first one is my student, Valerie Tapia, and the second is Sila Tiete. So let's first start looking at pneumococcal, what the incidence of the disease is. It is 3 times more per individuals in 100,000 in ages 18 to 34-year-olds. That incidence goes up significantly in ages of individuals 65 years and older. 36.4 incidences per 100,000 cases. 20 times more prevalent for children under the age of 2, and also for adults 65 and older with high-risk conditions such as diabetes, cancer, or other immunizing disease states. Pathophysiology of the disease we can look at is caused by the Streptococcus pneumoniae, a gram-positive catalyst, which is the leading cause of illness in the United States. Estimated 4,000 deaths occur. Most can cause an ear or sinus infection, pneumonia, meningitis, or bacteremia. It's most commonly spread around this time of the year in the winter and spring months by person-to-person contact by droplets in the air. Symptoms of pneumonia could include shortness of breath, chest pain, stiff neck, confusion, and irritability. So the first vaccine that we're going to look at that can help protect our individuals with this deadly disease is going to be the Pneumovax vaccine, which is also known as PPSV23. It's a polysaccharide vaccine, which consists of 23 pneumococcal serotypes. The serotypes are listed on the slide. If you look at the slide, you will see the ones that are in red. Those are the ones that are indifferent for the other vaccines that we will be looking at later. Pneumovax 23, also known as PPSV23, is recommended for adults 65 years or older. However, a good point to note is it's also recommended for individuals 2 through 64 who are at high risk of pneumococcal disease. Most of those individuals that would come into your pharmacy or into your doctor's office or ambulatory setting would be your patients that would have lung disease such as COPD, heart disease, sickle cell, diabetes, alcoholism, smokers, or individuals that are immunocompromised such as HIV or kidney failure or cancer. The other vaccine that we will look at, the second vaccine we will look at today, is called Prevnar 13, known as PSV13. It's a conjugated vaccine that we need to know that's the difference versus this counter vaccine, which is connected by polysaccharide linked to the protein conjugate. It consists of 13 serotypes, unlike the previous vaccine, which contains 23 serotypes. The ones that are listed on this slide, 1, 3, and the ones in bold, are the ones that differ from the other counterpart in the vaccine. It's approved for adults 50 years and older. ACIP, which is the standard guidelines that we use when we're vaccinating, also recommends that Prevnar can be used for adults 19 and older for immunizing conditions, which is mostly used in children. So we look at this slide. I know it's a little small, but if you look at it, it's a good reference slide to have in your practice. If you look down and it breaks it down to PCV13 and also the polysaccharide, the Pneumovax 23. Those can be used for individuals that are in immunizing conditions, if you look on the slide but it's mostly the Pneumovax 23 is used in individuals from 19 to 64 years of age in the immunizing conditions. The Prevnar 13, which is hard to saying these two numbers together, can be used, but it's more children under the younger age generation that you see that. So if a patient that comes into your pharmacy that is a heart patient, COPD, diabetes, and they're about 50 years of age, we would give them the Pneumovax 23 with the current guidelines. So this is a great reference that is followed by CDC, ACIP, and other big resources. It's showing the dosing schedule currently that we need to follow for the Prevnar 13 and the Pneumovax 23 for adults 65 and older. ACIP recommends that both be administered routinely in series to adults 65 years and older. So first we would follow, if we look at our slide, Prevnar 13 if the individual is 65 years and older. 1 year is the minimum guidelines based on CMS and Medicare billing, then we would give them the Pneumovax 23. If they got a Pneumovax 23 and it's before 65 and it's now that they've turned 65, it's been a year, we would give them a Prevnar 13. So once again, let me repeat that. If they're 64 and they had already gotten their Pneumovax 23 and now it's been a year, we would follow with the Prevnar 13. What about the individual who is your smoker or your diabetic and who was at 50 and got your Prevnar 13? So if you look at the last example on this slide, it shows that they would have gotten a Pneumovax 23 at 50. And now that they turned 65, they would have gotten the Prevnar 13. And then a year later, since it's been greater than 5 years, and that's the key to take away, they would now get a Pneumovax 23. So 50 years of age with diabetes or other immunization conditions, they would give the Prevnar the Pneumovax 23, year later, when they turn 65, Prevnar 13, and then a year later, now that they are, there's been 5 years since the first vaccine, the Pneumovax 23. These two slides, I put in this one and the next one as a reference. They look at the different dosing schedules on how to check on which vaccine we would give our patients. So who are the individuals who should not get vaccinated? Anyone with a serious allergic reaction to the polysaccharide. Anyone who's moderately or severely ill may be asked to wait until they recover to receive the vaccination. Children less than 2 years of age should not be vaccinated. And there is also no evidence that it is harmful to pregnant women or to the fetus. However, women planning on becoming pregnant should receive the vaccine prior to their pregnancy. What are some of the makeup schedule doses for mixed vaccines? I think I've covered this pretty nicely on the slide before. However, we'll go through it and read it again. If you received a dose of one or more doses of the Pneumovax 23, the dose of Prevnar 13 should be given 1 year after you got your most recent dose of Pneumovax 23. So once again, if they're 65, they've gotten already the Pneumovax, a year later, Prevnar 13. If they're 19 and have an underlying condition, for eligible individuals 19 years or older who have not received a pneumococcal vaccine should receive first the Prevnar if they have an immunizing condition, then followed by the Pneumovax 23. And the last phrase also repeats what we talked about. Eligible who are 19 years or older who previously received one or more doses of the Pneumovax 23 should also receive a dose of Prevnar 13 and continue to receive the remaining recommendation doses of Prevnar and Pneumovax 23. So let's look at the protocol in both Virginia and Maryland. Both states has a House bill that does allow pharmacists to administer the pneumococcal vaccine without the need of a prescription from a PCP. However, they do need to meet several requirements. Virginia requires the pharmacist to have a DS or Pharm D equivalent to administering the vaccine that fulfills the protocol requirements. And they must enter and document into the Virginia Immunization Information System, also known as VIIS. Maryland has similar requirements, and that vaccine, once it's administered, also should be documented into Immunization, which I'll go over further in more detail why it's important for us to document when we see that a patient gets the vaccine. By having both pharmacists in the state of Virginia and Maryland be on protocol to give the vaccine, this will help further increase the vaccination rates in those states. What could be some of the barriers that could impact from individuals receiving the immunization? The first and most important is insurance and cost. Some insurance policies do not cover vaccinations administered at the pharmacy. So in this situation, we might want to talk to the patient and say, hey, it might not be covered with us, but call your insurance, and if it's covered at your physician's office, highly encourage them to go back and get the vaccine with their physician. Patient education sometimes is also a hindrance. The patient might not understand, based on the new guidelines, that which vaccine should they get. There's 2 different ones, so many different strains. So sometimes sitting down and explaining to them, hey, even though you were 60 and got your first dose of Pneumovax 23, there is a new vaccine on the market now called Prevnar, and we do need to cover you for those other strands. Also, communication with the physicians and other healthcare professionals is also important, to making sure that we know which vaccines they got and if they're eligible. And most importantly, sometimes the vaccine is not entered into the immunization registry, Immunet for Maryland or VIIS for Virginia, and that can be a barrier because that would hinder the pharmacist from knowing if they should give a vaccine or not. So how can we take all this and increase the vaccinations in our neighborhood? We can form is called a key term that's come up with the American Pharmacy Association. It's called the Immunization Neighborhood. The concept involves new standards that places emphasis on the importance of collaboration among immunizing and non-immunizing healthcare professionals to meet the immunization needs of all patients and protect the community from vaccine-preventable diseases. Under the immunization standards, pharmacists have a phenomenal role to access the patient's vaccination needs, administer the necessary vaccines following state laws and regulations, document, which is important, and follow up with other healthcare professionals to ensure thorough and continuous patient care. So by working together, we can decrease the amount of individuals that are not vaccinated. The term definitely comes from collaboration, coordination, and communication of all immunization stakeholders, whether it's pharmacists, nurses, doctors, physicians, TA students, or other providers, to get to the ultimate goal of increasing our needs in the community. So the pharmacist's role in the implementation of the immunization neighborhood is trained pharmacists are the most accessible individual in the healthcare provider team that can help the nation's healthcare goals. Administration of vaccine and immunization services is lawful in all 50 states by pharmacists. Many healthcare plans, such as the Patient Protection Affordable Care Act, are requiring coverage of clinical preventive services, including vaccines recommended by CDC's ACIP guidelines. Pharmacists and community pharmacists provide an ideal location to implement these preventive services in a clinical, sound, and cost-effective manner and meet the growing needs of the patient's vaccination needs. So how do we do that and make sure we aren't causing any errors while we're vaccinating? We want to make sure that we look at the patient's age and comorbidities to determine eligibility. We would utilize the different registries in Maryland and Virginia, such as Immunization and VHQC, when assessing patient eligibility. We want to make sure that we're not giving a vaccine that they've already had, and that's why documentation is very important. If the registry is not up or if there's incorrect information in there, we need to follow up with our primary care physician before we vaccinate. Always double check the syringes to make sure the patient is not receiving the correct vaccine. If we are supposed to give them a Prevnar 13 based on the new guidelines, we don't grab a Pneumovax by mistake. If the patient is receiving more than one vaccine, such as their flu shot and their pneumonia shot, inform the patient which vaccine they're getting and they know what they're getting. And most importantly, document and also give the patient the VIS forms, which is known as the Vaccine Information Sheet, for each vaccine that's administered. So last but not least, we can tie all this part of the immunization neighborhood on increasing vaccination rates under what are called the new NVAC standards. So CDC recommended practice standards for healthcare immunizers in every one part of the immunization team. So the first standard is called ASSESS, immunization status for patients at every clinical encounter, whether that's in the pharmacy, the doctor's office, the public health area, or wherever. We want to stay informed with the latest recommendations, implement protocols and policies on what we can do to assess the situation. Once we assess what they need, we would strongly recommend the vaccine the patient needed. Describe the benefits if there's any hesitancy on getting the vaccine and the cost of getting sick. We address the patient's questions and concerns. The next two standards will be administer, refer, and then documentation. I think each one is clearly important. So once we recommend and if they know that they need the vaccine, we want to administer given that opportunity. If we cannot administer a vaccine at the pharmacy, we want to work with our local partners and refer the patient to a vaccine provider. Offer the vaccines you have in stock, but if we can't, then make sure you refer them to a physician or a healthcare provider in your community that can vaccinate them. And most importantly, document. Patient needs to know that the vaccine was administered, given them any kind of immunization record card, and make sure it's updated in the state's immunization registry. And follow up with the patient to see if they had any questions or concerns. Now, at this time, I would like to take this opportunity and introduce once again one of the co-authors of today's webinar, Sheila, who is going to talk about this first case study going over on the two different vaccines. All right. Thank you, Sheila.
All right. Thank you for the introduction, Dr. Madmadar. So go ahead with case number 1. We have a 70-year-old male who presents to the pharmacy picking up his routine medication and for his annual flu shot. His past medical history included asthma, type 1 diabetes, and hypertension. So the first question is, based on the patient's age and risk factors, what should be the initial recommendation? We have A, Prevnar, B, Pneumovax, C, the annual influenza vaccine, or D, both A and C. So now we'll give a moment for the audience to vote.
So just as a reminder, once you've selected your answer choice, please click the Submit button in the bottom right-hand corner after you've made your answer.
All right, poll has ended, and hopefully majority has chosen B. And that is correct. So based on the patient's risk factors and age, he needed to get the influenza and the PCV13. So the answer is D, should have received both A and C. So moving on to the second question. Question 2. After checking the internet, the patient has a history of having received the Pneumovax at the age of 65. What might be the new recommendation? A, Prevnar, B, Pneumovax 23, C, both A and B, or D, none, because he has already been vaccinated and does not require any further vaccination. So again, we'll give a moment for everyone to vote. All right, polling has ended. The correct answer is A, and it seems like majority has gotten that correct. So patient has already received his Pneumovax, and based on ACIP guidelines, he needs to go ahead and get his Prevnar first, and then later on followed by another Pneumovax, because that has already been greater than a year after his first Pneumovax. So now I'm going to go ahead and introduce the second co-author, Valerie Tapia. She can go ahead and present the second case of questions.
Thank you, Sarah, for that introduction. Case number 2, a 55-year-old male presents to the pharmacy to receive his annual flu shot. He informs the pharmacist that he was recommended by his doctor to receive the vaccinations due to his comorbidities of COPD and diabetes. So question 1. Based on the patient's past medical history, what other vaccinations should be recommended? A, Prevnar, B, Pneumovax, C, Tdap, or D, both A and B. And I'll give you guys time to vote. Okay, I was waiting for the poll to show, but I hope a majority of you guys got B as your answer choice. Because of the patient's age and immunocompromising comorbidities, you would vaccinate him with the Pneumovax. And it looks like a majority of you guys picked the Pneumovax. So for the same patient, for question 2, he presents to the pharmacy 10 years later. He is now 65 years of age. His physician said he will be needing a pneumococcal vaccine, but he's already received one previously at your pharmacy. What vaccine should be recommended at this time? A, Prevnar, B, Pneumovax, C, Tdap, or D, none. He's already been vaccinated and does not require further vaccinations. And again, I'll give you time to vote. So the answer choice is A. The patient is 65 years old, and the Prevnar 13 is recommended for all patients greater than 65 years of age. In addition, it is greater than 1 year since he's received the Pneumovax. So it's appropriate to administer the Prevnar 13 at this time. For the next question, after administering the Prevnar 13 to the patient, he asks if there's any other things he should know about the pneumococcal vaccines. What follow-up should you recommend for this patient in the next year? Prevnar 13, B, Pneumovax, C, Tdap, or D, none. He's already been vaccinated and does not require further vaccinations. Okay, and the answer choice is D, the Pneumovax. It's been greater than 5 years from his first dose of Pneumovax, which he had received at 55 years of age, if you remember from the first question, and it's also greater than a year from the Prevnar 13 vaccine. So you would recommend the second dose because he's over 65 with the immunocompromising comorbidities. So on behalf of Mona, Steele, and myself, we would like to thank you for your time and participation, and we'd like to open up the floor for any questions.
The floor is now open to your questions. If you have a question or comment, please press 7 on your telephone keypad.
While we're waiting for questions, I just want to remind everyone that you can also drop a question into the chat on the right-hand side of your webinar screen. And additionally, just to let you know, Mona and her team will be on the phone line with us for the remainder of the webinar if you have additional questions that may come up. Mona, while we're waiting as well, I do have a question for you. In terms of patient education about the types of vaccinations, what do you suggest for pharmacists and folks to share with their participants or their patients? How do you help the patient to also understand this and to be able to go to their immunizer and their doctor and to ask for the appropriate vaccination?
Are you saying that, how do they know which vaccine to get at the current right time, or just so I think our biggest opportunity is always talking to our seniors and other individuals. If we see a patient comes in, definitely in the flu season, it's easy to talk to individuals about their vaccination needs, but non-flu time, if we have an individual who's diabetic or who's the heart, if they're COPD or asthmatic or they're any of those conditions, they're a smoker, when we're filling those prescriptions for them, that's the time we educate them. And sometimes they might not take that advice, and we tell them to talk to their physician. If we have a chance when we're talking to their doctor's office, we make a point to say, hey, this patient might benefit from a certain vaccine, we can have that talk, or we'd like for you to make a note of it next time they're in the office.
Great. Thank you, Mona. That's very helpful. And certainly, we always want to involve our patients and families in the conversation, and it's certainly helpful to hear that. Wes, can we check to see if there's any questions for Mona and her team?
At this time, there are no questions, but as a reminder for a question or comment, please press 7 on your telephone keypad.
Okay. Well, Mona, thanks for sticking around with us. And if there are other questions, we'll certainly ask you at that time. Well, moving on, I just want to share some information on our next presenter. Mr. Tom Bateman works in vaccine account management at Pfizer, where his role is to increase immunization compliance among all ages. He joins us today to share information on Take a Stand, a training initiative to improve adult immunizations using standing orders in physician offices. So at this time, thank you so much, Mr. Bateman, for joining us. Tom, the floor is yours.
Thanks, Erica. Can you hear me okay?
Yes, come through loud and clear.
Great. Appreciate the opportunity to chat with the audience this afternoon. We'll just spend a few minutes describing some logistics and some background about the workshop and answer any questions folks have and give some pertinent details on how to get connected. So each year, vaccine-preventable diseases kill thousands of adults in the U.S., and it causes a significant human toll and severe economic burden on our healthcare systems. And unfortunately, adult immunization rates remain low with long-standing gaps between national goals and adult immunization rates. I think we saw some information about that earlier in the talk. So healthcare providers serve a critical role in vaccination, but they're increasingly challenged by time patient treatment focus, and prioritization of other preventative measures. The strength and impact of a healthcare provider's recommendation is paramount to overcoming low compliance rates. Thus, it's increasingly important that every healthcare professional who has competence to provide immunization assessment and recommendations and to administer vaccines be empowered to do so. Fortunately, there's strong evidence showing that the use of standing orders in medical practices can improve immunization rates in the adult population. Standing order programs, or SOPs, authorize nurses, pharmacists, physician assistants, or medical assistants, when permitted under state law, to assess a patient's immunization status and then administer the needed vaccines according to standing orders that have been pre-approved by a physician or another authorized provider. SOPs are recommended by the Centers for Disease Control and Prevention and by the United States Community Preventative Services Task Force. Regrettably, however, standing orders are not being utilized sufficiently for adult immunizations. Recent studies demonstrate low utilization of this proven strategy. One study in particular indicates that only about 23% of internal medicine and family medicine physicians reported consistent use of SOPs for both influenza and pneumococcal vaccines. An increase in utilization of SOPs in medical practices can be achieved through a sustained provider education effort. An optimal education program should include demonstrating the value of standing orders programs and providing clear instruction about the requirements and steps needed for implementation. Additionally, the training should inform vaccinators about specific regulations in their states that control who is allowed to administer vaccines using standing orders, thus dispelling misunderstandings that create false barriers to implementation of a standing order. Can you go to the next slide, please, Erica? Thanks. So what is Take a Stand? It's a new national program developed by the Immunization Action Coalition, or the IAC. It's in partnership with Pfizer, aimed at boosting adult immunization rates through increased utilization of standing orders in medical practices. The program is being offered to medical practices and facilities of multiple sizes that are currently administering at least one adult vaccine. The IAC will provide basic support to these practices for 1 year following their participation in the training workshop. The no-cost interactive 4-hour workshops are being conducted in at least 20 locations across the country. I'll talk more about that in a minute. They're led by a multidisciplinary team of experts in adult immunization, and each workshop has 5 goals. One is to reinforce the value of adult vaccines. 2 is to demonstrate the benefits of instituting standing orders to raise rates within our practices. 3 is to explain the legal principles related to using standing orders. 4 is to address the perceived challenges to implementing standing orders as identified. And 5, finally, is to provide instructions on establishing and implementing standing orders. So how will this benefit patients or practices? This program will train practices to implement new SOPs or improve SOPs that are currently in place. The program also provides a year of support from the IAC, as I mentioned before, to assist practices in implementing these standing orders. And in addition to raising adult immunization rates, Take a Stand workshop will improve patient care through enhanced practice efficiency in delivering adult vaccines. It will streamline clinician time in providing vaccinations to adults. And finally, to provide access to evidence-based tools, model standing orders, and a step-by-step guide for improving the SOP and enhancing the quality of patient care. So, as you can see on the slide, there's a great website you can go to for more information. And if you can't see the slide, it is www.standingorders.org. And the schedule of events, I mentioned it's being run in about 20 markets or so. I know this is an East Coast audience with specificity to Maryland and Virginia. So probably the closest location would be the Baltimore, Maryland site, which is coming up in June. But there are actually a number of East Coast trying to pull the schedule here. There are other East Coast locations. So if you have a hankering to travel, there are, let's see here, I'm pulling up the Southeast. If you have any interest in heading down to Florida, there are workshops on both April 12th and April 13th in Orlando and Fort Lauderdale. Also on April 15th in Atlanta. And then in the Northeast, there's Boston on June 6th, New York City on June 8th, Philadelphia on June 9th, and then that Baltimore workshop on June 11th. So all the information is located at the website there, thestandingorders.org, and you can find links to all the pertinent details there. So I want to thank you for the few minutes to share this resource with the audience. And if there's any questions, I'm happy to answer those at this time.
Thank you so much, Tom. I know that you provided a take a stand workshop backgrounder, the PDF.
Yeah, I'm sorry, I forgot that was over there. If you could talk a little bit about that. And this is basically an overview of everything I just reviewed. So I don't know if the VHQC can make this available to the audience somehow, but it's certainly also available through one of the web links. So this basically gives all the background that I just reviewed with all the pertinent website links and so forth.
Great, thank you so much. We certainly will. We have an online community, and we will certainly post this along with the slides from today's presentation. Well, thank you again, Tom. Wes, can you remind folks of how to ask a question?
Certainly, again, as a reminder for a question or comment, please press 7 on your telephone keypad. At this time, there are no questions.
Well, Tom, I think you just did a fantastic job of covering that material. Thank you so much. Of course, there is, again, the website and a registration for that upcoming workshop. So thank you once again for joining us, Tom. And just before we move on for a moment, I just want to remind everyone that before you leave us today, we appreciate for you to complete the evaluation that will show up on the webinar platform on the right-hand side of your screen. We appreciate and need your feedback. So moving on into just a Q&A for this webinar for the rest of the time we have left together. I do see we have a question in chat from Mona. Mona, it reads, what is the reimbursement for Prevnar use in adults?
So it all depends on the insurance company and whatnot. We've seen really great reimbursement for Medicare recipients, so it's been covered for their Medicare. Private insurance, it depends on their plans. We've seen anything from zero copays to $50, $100 if they have a deductible or not, especially at the beginning of the year. During flu season, most everyone's Prevnar was covered at zero. So it all depends, but Medicare is covering it.
Great, thank you so much. Liz, are there any other questions for Mona or Tom?
At this time, there are no questions.
Okay. Well, we are just delighted to have Tom and Mona with us today, and hope that that if there are questions on the line, or if there's any feedback for us, we look forward to receiving it. I will let you know again, as mentioned earlier, that if you'd like to have a copy of today's presentation, it's been placed on our online community, and that is at the link you'll see in chat. And if you haven't already joined the community, you'll want to do that to access the presentation handout and other resources. There are also other tools and resources to assist you with improving immunization. Looking at chat, looks like we have another question that came in. Lana or Tom, what are the side effects of PDC-13 versus I just lost the question, versus PPSV-23?
So they're both Can you hear me?
Yes.
Okay. So for PCV13 versus the Pneumovax 23, they're pretty much both redness, irritation at the injection site, but generally it's very well tolerated, just muscle pain and whatnot else. Very few side effects, if any, unless they have a known component to having any allergies, but I've been giving hundreds of them each season or more, and haven't had anybody complain, except like maybe the little muscle stiffness. I do see there is another question in here. Should a healthy 50-year-old patient with no risk condition receive Prevnar 13? No. It's generally the new ACIP guidelines state it's reserved for individuals 65 and older. So unless they have any health conditions, there's no indications for that.
Thank you, Lana.
Hope that answers your question.
Okay. If there are any follow-up questions from the last two chat questions, we're happy to take them. Either drop your follow-up into the chat function, or you can get on our audio line to ask as well. And Wes, can you give us that number one more time?
Certainly, again, as a reminder, for a question or comment, please press 7 on your telephone keypad.
We'll just pause for a moment. Okay. All right. Well, Mona or Tom, do you have anything else you want to add, or?
No, I would just like to thank everyone at VHQC for giving us the opportunity to hear me and my co-authors on presenting the webinar for the two different pneumococcal vaccines.
Yeah, nothing further from me. Just thank the opportunity to connect with the audience to share what hopefully will be a valuable educational resource. So thank you.
Great. Thank you so much. And as we close today's webinar, I just wanted to take an opportunity to introduce my colleague and your contact for the immunization work being done in Maryland. Angela Cochran was the former Director of Chronic Disease Prevention and Control at the Department of Health and Mental Hygiene at St. Mary's County Health Department. And now she is here with us at VHQC, working with healthcare providers to really bring about large-scale change and improvement related to adult immunizations in Maryland. So I know she looks forward to connecting with you all. And if that is all we have, this is the end of the webinar. Thank you again for your time and attention today. And we will be in touch again with putting this webinar onto our online community, and as well as all the documents that were provided today. Thank you again, and take good care.
Thank you, Lisa. Have a great day.
You guys too. Bye-bye.
Thank you. This concludes today's teleconference. We appreciate your participation. You may now disconnect your line at this time.